Welcome to the presentation on cigarette smoke-related lung injury, anatomy, physiology, and imaging. My name is Jeff Galvin, and I'm professor in the departments of radiology and internal medicine at the University of Maryland. Additionally, I'm chief of chest and mediastinal imaging at the American Institute for Radiologic Pathology. I have no financial relations to disclose regarding to this presentation. Upon completion of this presentation, you should understand the pathophysiology of cigarette smoke-related lung injury and should be capable of describing the range of imaging findings associated with cigarette smoke exposure. You will be equipped to de-emphasize the current legacy categories, resulting in a more useful diagnostic approach. And finally, I hope you will be able to utilize this approach in a multidisciplinary clinical setting to improve patient management. Exposure to cigarette smoke is common, and a large percentage of the images that we interpret were acquired from cigarette smokers. The lungs of a 60-year-old person with 40-pack-year history of smoking has been exposed to more than 300,000 cigarettes, billions of toxic particles, and more than 5,000 compounds, many of which are carcinogenic. This complex inhalational challenge initiates an inflammatory, immune, and in some cases fibrotic response in the airways and the lung parenchyma of cigarette smokers. An inflammatory response is seen in all cigarette smokers and is represented by the cells that you see in the left upper corner of your screen. Here are a compilation of macrophages and dendritic cells, also known as Langerhans cells. Some degree of inflammation is present across all these categories of smoking-related diffuse lung injury, as shown by the yellow line that spans all these categories. A small number of patients will have emphysema, and an even smaller number, but still a substantial number, will have true fibrosis of the alveolar walls, demonstrated here on the right side of your screen. You will notice that the categories go from inflammatory, which include respiratory bronchiolitis, desquamative interstitial pneumonia, pulmonary Langerhans cell histiocytosis, and these areas of inflammation are associated with emphysema. Finally, as mentioned before, there is a category of diffuse pulmonary fibrosis and superimposed on areas of emphysema, in which there are focal areas of low attenuation in the mid and upper lung zones. It is important for us to differentiate this form of fibrosis from the alveolar collapse and honeycombing that also causes cysts within the lung, which are predominantly in the mid and lower lung zones. We will now proceed to look at each of these categories, starting with the inflammatory lesions. Inflammation, again, macrophages, which you see in your upper left, and pulmonary Langerhans cell histiocytes are part of the inflammatory process to the response of cigarette smoke. Respiratory bronchiolitis, desquamative interstitial pneumonia, which you see in the middle, and pulmonary Langerhans cell histiocytosis are often seen in combination. First, let's start with respiratory bronchiolitis. RB, as it is sometimes called, was described by Dennis Neuanner in 1974 in the New England Journal of Medicine in patients who died of other causes. You will note that there are highly pigmented macrophages, and the deep brown pigmentation, it correlates well with the amount of cigarette smoke that the patient is exposed to. A greater number of cigarettes results in increasing pigmentation of these cells. The cells themselves are found in and around small airways, therefore the term respiratory bronchiolitis. You'll notice that the brown cells are in the middle of this small airway and in and around the airway itself. Only approximately 20% of the patients with respiratory bronchiolitis on histology, which is essentially 100% of smokers, will have changes on imaging, and often they are subtle. Here we see small ground glass nodules in a central lobular position, some of them with an almost Y-shaped configuration in and around small airways. These are subtle changes, but represent the changes of respiratory bronchiolitis. You will note that respiratory bronchiolitis is predominantly an upper lung zone disease, as most chronic inhalational lung diseases are. Some patients who have respiratory bronchiolitis determined on histology and or seen on changes that are typical of imaging will be labeled by the clinician as respiratory bronchiolitis, interstitial lung disease. It is important to recognize that the definition for RBILD is not clear, and as Ethel Wells, one of the best-known pulmonary pathologists who lives in England, says, the distinction between respiratory bronchiolitis and RBILD remains a nebulous gestalt of clinical, functional, and HRCT findings. So it is important to recognize that neither the pathologist nor the radiologist make the diagnosis of RBILD. In this 30-year-old who is a heavy smoker and was dyspneic with pulmonary functions that had mild restriction, the pathology reveals the typical smoker's macrophages we have talked about. There is quite a bit of fibrosis around this distorted small airway, and yet an experienced pulmonary pathologist will not make the diagnosis of RBILD. All they can say is that there are changes of RB and there is some fibrosis, which is seen in cigarette smokers. You and I may well see the ground glass nodules, which are typical of RB, again, more upper lobe than lower, but recognize that finally it will be the clinician who will put this together. Neither the radiologist nor the pathologist make the diagnosis of respiratory bronchiolitis, interstitial lung disease. Desquamative interstitial pneumonia can be thought of as an exaggerated response of respiratory bronchiolitis. The fact that these are the same spectrum was nicely demonstrated by Laura Heinemann in 1999, and most people believe now that respiratory bronchiolitis and desquamative interstitial pneumonia, or DIP as it is sometimes called, are just all the same cells, the only difference being that in RB, the cells are predominantly around the small airways, which we see in the right upper lobe here. In DIP, there's extension of the same cells out into the alveolar spaces. This is a more diffuse and more severe disease, but it is not a different disease. It was, however, described by Averill Liebau in the late 60s. At that time, he thought that respiratory bronchiolitis was different from DIP, and that desquamative interstitial pneumonia was, in fact, a case in which there were cells that were falling out of from the alveolar walls and that they were type 2 pneumocytes. We now know that RB, which you see on the left, which are those brown macrophages in the middle of the airway, are the same macrophages that you find within the alveolar spaces, and it is really a difference of extent and anatomic placement than it is a difference in disease. It is important to recognize that from the very first description of desquamative interstitial pneumonia, that a certain amount of alveolar wall fibrosis was described. So this is part of the diagnosis of DIP. You will notice here that the alveolar walls have marked pink collagen throughout them. The changes that are associated with DIP, in other words, the macrophages are in the alveolar spaces. You and I, as a radiologist, will typically see diffuse or patchy areas of ground glass. And it is important to recognize that it is the combination of cells within the alveolar spaces and thickening of the alveolar walls that results in this ground glass. However, it is important to remember that alveolar wall thickening alone or cells alone can also give you ground glass, and it is very difficult for us in radiology to tell the difference. In patients who are cigarette smokers, obviously respiratory bronchiolitis may be a typical cause of central lobular ground glass nodules. But there are certainly other causes, and this is what part of the nightmare of cigarette smokers with multiple ground glass nodules. This patient underwent an open lung biopsy because of this more solid nodule in the anterior portion of the right upper lobe. You will notice that there are numerous small 3 to 4 millimeter ground glass nodules throughout both lungs. The open lung biopsy in this patient revealed that the solid nodule was in fact a nodule of pulmonary Langerhans cell histiocytosis, and that the majority of the other ground glass nodules were areas of respiratory bronchiolitis in which there were typical inflammatory cells around small airways. However, one of these ground glass nodules, and I can't tell you which one it is, was a pre-malignant lesion, which you see in the right lower portion of your screen. It was an area of atypical adenomatous hyperplasia, or AAH. And so this is part of the nightmare of following smokers who have multiple nodules. This brings us to the third and final inflammatory lesion associated with cigarette smoke, and that is pulmonary Langerhans cell histiocytosis. This is basically a histiocytosis which is localized to the lungs alone. It is nearly 100% related to cigarette smoke exposure, and it is often part of other forms of smoking-related lung injury. It is common when someone sees PLCH, as it is called, to also see respiratory bronchiolitis, DIP, emphysema, and other forms of fibrosis. On the right-hand side, you see the typical cells of pulmonary Langerhans cell histiocytosis with the strikingly folded nuclei. There's usually a combination of cells with eosinophils and neutrophils. This is the typical findings in a patient with pulmonary Langerhans cell histiocytosis. A Langerhans cell is a dendritic cell, and dendritic cells were originally described by Steinman and Cohn back in the 70s, and they have this peculiar stellate morphology. What's important about dendritic cells is that they are antigen-presenting cells. This is part of the way in which the lung protects itself. Antigens which you inhale are picked up by dendritic cells. These dendritic cells are able to migrate to lymphoid organs, at which point they are processed. So they are an important part of the defense of the normal lung. And when you bombard the lung with cigarette smoke, it appears to stimulate dendritic cells in certain populations of patients. On your left-hand side are the typical dendritic cells with their folded nuclei. If we look into the interior of this Langerhans cell, we will find the typical organelle, which is called the Birbeck body, approximately 400 nanometers in length and 30 to 50 in width. It is a pentalaminar body, and it is proof positive that this is a Langerhans cell. Very rarely do we see this done anymore because of the complexity of electron microscopy, and most of the time the diagnosis of Langerhans cell histiocytosis is done on light microscopy and immunohistochemistry. If we look at the findings associated with PLCH, they start with nodules, and this illustration on your left is a complete description of the typical findings and progression of pulmonary Langerhans cell histiocytosis. You will note that the first change is a nodule, and that nodule is associated with an airway. Over time, that Langerhans tissue and the inflammatory cells which I showed you will invade the alveolar wall, weakening it and allowing it to dilate, creating bizarre-shaped cysts. Over time, the disease tends to burn itself out, and the cells disappear, leaving a nodule of fibrosis. And remember that fibroblasts contract, and as they contract, we get paricicatricial emphysema around the stellate burned out scars of late phase pulmonary Langerhans cell histiocytosis. All of these changes, however, are predominantly mid and upper lung zone. So now let us explore the changes of PLCH individually. As we said, the very first change of pulmonary Langerhans cell histiocytosis is an airway-associated nodule. The nodule is usually indistinct because of the stellate extensions of cells and fibrosis that you see in the image on your right. This nodule is always associated with an airway, which you see also on the histology, but you and I as imagers rarely get to see the airway association, but it is always there on the histologic image. As we said before, these nodules are almost always in the mid and upper lung zones, as most chronic inhalational lung diseases are. As the disease progresses, we tend to get the Langerhans cells and some fibrotic material invading the wall of the airway itself. This weakens the wall, allowing it to dilate. So these funny irregular cystic shapes that we see that are represented on the imaging on the right-hand side are the result of invasion of the airway wall itself. As the disease progresses, we see a combination of both thin and thick-walled cysts. Most of them have a markedly indistinct border. They begin to assume bizarre shapes. All of this is because we are imaging airways in various orientations. If we look more closely at the airway, we can see again that it is being infiltrated by a combination of these little blue dots, which are inflammatory cells, and fibrous tissue, and the airway wall is being destroyed. As it is being destroyed, we begin to see these dilated airways that present as bizarre-shaped cysts. This was proven by Marianne Kamm-Buchner by doing three-dimensional reconstruction of histology. You will note that they have the problem, and when they look at cysts at individual levels, it's hard to tell what the entire structure is. But she was able to reconstruct them using the same sort of software that we use in 3D imaging, and showed that the airway in green here forms this oblong cyst, and depending on how it is sliced, it will either be circular or oblong or V-shaped, and that the histiocytic material, which is colored in red, is what is left of the airway wall that surrounds the cyst itself. As the disease progresses and you begin to get fibrosis of the airways themselves, you will get enlargement of the cysts, and they assume this bizarre shape. The larger the cysts become, the more likely it is that the patient will present with a pneumothorax. In the so-called burned out phase of pulmonary Langerhans cell histiocytosis, all of the cells have disappeared, and we are left with contracted scars. These contracted scars result in paracicatricial emphysema. As far as we're concerned, this looks like typical emphysema. The patient is hyperinflated. There's low attenuation in the upper lung zones. If we look at the coronal image, this would be typical bullous emphysema. I really don't see any cysts. The gross image that correlates very nicely with this shows that there are, in fact, cystic spaces with very clear walls, but it's difficult for us to see them. And the histology from this case shows these beautiful small scars which have no more cells left in them. The scars are contracting, and as they contract, they form paracicatricial emphysema. So this is the late phase of PLCH. One more point before we leave PLCH. Sometimes there is evidence of PLCH histologically that you and I do not see as imagers. The image of the right upper and right mid lung zone, which you see here, shows diffuse ground glass with airways that are irregular and slightly dilated, suggesting underlying fibrosis of the alveolar walls. But I don't see small nodules to even raise the possibility of pulmonary Langerhans cell histiocytosis. This case from the Joint Pathology Center shows definite scars of burned out PLCH. So it is a far more common disease than we as radiologists recognize, and is often combined with other forms of inflammatory and fibrotic smoking-related lung disease. That brings us to emphysema. We know that that emphysema is part of the chronic obstructive pulmonary disease, and that despite the fact that the number of cigarettes per individual within the United States has been falling since the mid-'80s, the number of patients dying of chronic obstructive pulmonary disease continues to grow up at a rapid rate, and that the number of women dying of COPD has now exceeded the number of men, suggesting that the deleterious effects of cigarette smoke resulting in COPD are more serious in women, and that women are more sensitive to the cigarette smoke. In 2015, the Fleischner Society published a white paper on the CT-definable subtypes of emphysema and chronic obstructive pulmonary disease, and it is a useful review of the subject. Clearly, in this short time, I cannot review all of this, but just to recognize that emphysema is divided into central-lobular, which is what we're going to talk about in a few minutes, panlobular, which we tend to associate with alpha-1 antitrypsin deficiency and is predominantly a lower lung zone process, and paraseptal emphysema, which is peripheral and along the pleura and may be seen in non-smokers. But we should recognize that cigarette smokers with central lobular emphysema can have such severe emphysema that it becomes panlobular and will involve the entire lobular. And in fact, the most common underlying exposure in patients with paraseptal emphysema is cigarette smoke exposure. With that, let's talk for a few minutes about central lobular emphysema. We know that this is predominantly a mid and upper lung zone process, that you and I see areas of low attenuation, usually without definite walls. It is important to recognize that emphysema follows the same distribution as respiratory bronchiolitis, and it is believed that part of the reason that we have emphysema in the upper lung zones is that the elastases that are part of macrophages and inflammatory cells are part of the reason that alveolar walls are being destroyed. Alveolar walls are part elastin, and the elastases in the increased number of white cells helps dissolve the normal alveolar walls. In addition, there is increased strain in the alveoli at the top of the lung. John West, many years ago, showed that the alveoli and alveolar walls at the top of the lung are under 3 times the strain as the alveolar and the alveolar walls at the base of the lung, and this is due to the lung weight itself. So when alveoli are weakened, they are more likely to fail in the top of the lung. Probably some combination of the inflammatory cells, elastases, and strain may all contribute to the fact that emphysema is more likely an upper lung zone. Before I leave the topic of emphysema, I would like to commend to you this paper that comes out of Jim Hogg's lab in Vancouver. This is written by John McDonough, and I think elucidates a greater understanding of the causes and relationships between emphysema and small airways disease. It's the first time that we've really seen these things, and he used micro-CT as a technique to look at small airways and their relationship to emphysema. And what he found was that patients with a significant emphysema, in fact, these were people who had their lungs removed to put new lungs in, who were undergoing lung transplant, that when they took the lungs out and looked at them, they found that there was substantial destruction of small airways. And I'm going to step you through one of these micro-CT sections. At the bottom, we can see one of these small terminal bronchioles. And before micro-CT, people just assumed that they just didn't have the complete airway within the slide or within the plane. But what we find as we look through, if we go down, we can see that if we look a little bit lower, that the airway actually is gone, that there are areas of central emphysema, and that the terminal bronchiole, even as we go to the next level, is in fact completely obliterated in the region where there is significant emphysema. And as we finally go to the base, we see a little bit more of the airway, but it is completely destroyed. And in the region of the completely destroyed central airway are the most significant areas of emphysema. And what Jim McDonough and James Hogg has shown is that patients with significant and severe emphysema have lost more than 90% of their small airways by the time they develop severe emphysema. And in fact, the first lesions of chronic obstructive pulmonary disease are destruction and obliteration of small airways. If you look here at the cross-sectional area of terminal bronchioles, in the normal individual, it's over 3,000 square millimeters. In the patients with severe emphysema, it has gone down to 7 square millimeters. More than 90-some-odd% of the airways are destroyed, and this is something that we've never known before, and it is likely that emphysema is a secondary response to significant airways disease. This brings us to our last topic, which is fibrosis. And there are two forms of fibrosis that I would like to discuss. One is the diffuse form of fibrosis that is directly related to the inhalation of cigarette smoke. And the second is idiopathic pulmonary fibrosis. We know that, although it is probably not the direct cause of IPF, we know that in most studies of patients with IPF, that more than 70% of the people who are diagnosed are cigarette smokers. So it's not uncommon for us as radiologists to have to make that differentiation. So if we look at these two diseases first right now, the one on your left, which has been called airspace enlargement with fibrosis, is essentially areas of emphysema with diffuse fibrosis represented by this blue color throughout the lung. In this case, there's diffuse alveolar wall thickening, but the secondary lobules are completely expanded. In idiopathic pulmonary fibrosis, the cysts are true honeycombing, which are actually dilated respiratory bronchioles, and the secondary lobule, which you see here as normal, now becomes just a small collapsed lobule with a dilated airway within the middle. So what is most important to me is looking at where the cysts themselves are. So let's look at this in greater detail. First, let's talk about this concept of diffuse alveolar wall fibrosis in patients who are cigarette smokers, which has been called airspace enlargement with fibrosis. There are other terms for it. It's been called combined emphysema, pulmonary fibrosis and emphysema, CPFE, and a number of other terms. But we'll use airspace enlargement with fibrosis for this. The first thing to recognize is that the association between smoking and fibrosis is old, that it was very well shown by Oscar Auerbach in New York with thousands of autopsy cases, that if you look at the number of packs of cigarettes that somebody smokes and the number of years that they smoke, that there's an almost direct relationship between cigarette exposure and the degree of fibrosis. And this is typical deposition of alveolar wall collagen. And this has been repeated multiple times, both by Auerbach and a number of his compatriots. This is old and very well done work. It's also been shown in laboratory animals. This was done in dogs, and has been shown that when you expose an animal as a dog to cigarette smoke, that within months they will develop alveolar wall fibrosis. In fact, here's the non-smoking lung and electron microscopy. Within a couple of weeks, they develop the macrophages that we showed you in humans, and within 6 weeks, they then develop collagen deposition within the alveolar wall. So been very clearly shown in men and women. It's been shown in laboratory animals. And is it once again this same type of fibrosis is now being talked about. There have been at least a dozen articles in the last 10 years talking about interstitial fibrosis in smoking. In this case, Anna Louise Katzenstein talks about this as being surprising. It's not all that surprising, and it's very common. One of the problems is that it has been difficult to assess its clinical importance. And one thing I want to leave you with is that in most articles they say that, yes, they've known that this fibrosis has been there. It's rarely reported even if they see it because they assume it's not very important. And the reason they say that is this, that when you have a combination of fibrosis and emphysema, spirometry and pulmonary functions are usually normal, even though the diffusing capacity is low. So if you look at these people who have a combination of fibrosis and emphysema that their lung volumes are normal, their residual volume is normal, their FEV1% is nearly normal. So it's very difficult for them to make the diagnosis based just on the pulmonary functions. And it is the combined effect of fibrosis and emphysema. It appears that the fibrous alveolar walls hold the airways open, and these people are severely dyspneic, and this is in fact a very important form of fibrosis. The typical imaging looks like this, which are cysts, usually very well circumscribed because of surrounding fibrosis. These are actually areas of emphysema, and they follow the normal distribution of emphysema. And you will see that there are widespread areas of ground glass opacity in both lungs. The degree and the distribution of ground glass opacity is often different from one patient to another, but this is the archetype appearance of patients with airspace enlargement with fibrosis. If we look at the histology associated with this, again, we see that this is an emphysematous space. There are smokers' macrophages, not surprisingly, in the alveolar space itself. There is fibrosis in the alveolar wall. And that this space correlates well with these very well circumscribed spaces which we see here. Now, if we just take them in isolation and don't recognize that they're throughout the upper lobe, it would be easy to mistake them for an area of honeycombing. Again, honeycombing is just a cyst and with a definite wall around it. But here you'll notice that the cysts and walls are most prominent in the upper lung zones and disappear where you go down to the lung bases. So I think the easiest way to show you is that I have some illustrations which we had made based on the literature which I just told you, and helps explain how you go from a normal lung on the left to this lung of fibrosis that surrounds areas of emphysema on your right. So let's start with the normal secondary lobule, which you see here, and the normal lung on your left. Here, the entire secondary lobule with the terminal bronchiole, respiratory bronchiole, alveolar ducts, and the numerous alveoli that fills this secondary lobule. Secondary lobule is usually a centimeter or two in diameter. And in patients with the formation of emphysema, as we pointed out by McDonough and from Jim Hogg, that the initial injury is actually destruction of the terminal bronchiole with subsequent centrolobular emphysema, which forms in the center of the secondary lobule. This is typical emphysema, and you and I are going to see holes in the mid and upper lung zones. As the disease progresses, there is more and more destruction of alveolar walls, until finally it is possible to have the entire secondary lobule be essentially destroyed with airspace enlargement and broken alveolar walls. If the patient is a heavy smoker, a certain percentage of them will actually deposit collagen in the walls of the alveoli, almost as a reparative response. At this point, you and I are going to see increasing ground glass density throughout the lung, and the focal areas of emphysema are going to be much better delineated because of the surrounding fibrosis. You will note that the secondary lobule, which I pointed out before, and this is the tip of a lung, this is a complete secondary lobule bounded by the pleura here and by the intralobular septum here. And you'll note that there are emphysematous spaces and that the alveolar walls are thickened, some worse areas than others. But the secondary lobule itself is fully inflated. This is the typical change of airspace enlargement with fibrosis. Let me contrast this with idiopathic pulmonary fibrosis. There's only one good quantitative study that looks at the pathophysiology of IPF, and this again comes out of Jim Hogg's lab, and it was done by Harvey Coxon in the late 90s. And what he shows is that patients with idiopathic pulmonary fibrosis suffer substantial alveolar collapse. There's actually very little fibrosis in pulmonary fibrosis, but that's for another talk. But what he does show is that the tissue volume in patients with IPF is normal, but what happens is that they've lost most of their volume. Here controls almost 4 liters. Here IPF, the amount of air in their lungs has dropped in half. And let me show you what is happening here. Again, using the secondary lobule as a way of explaining this. What we find is that in patients with idiopathic pulmonary fibrosis, there is some form of diffuse lung injury that we don't understand yet. These injured alveoli with damaged type 1 cells and lactive surfactant, that the alveoli in the periphery of the secondary lobule begin to collapse. As they do, they begin to have a tractive force on the central airways and begin to pull the central airways open. As the disease progresses, there's more and more collapse of these alveoli in the periphery of the secondary lobule, and the central respiratory bronchioles and alveolar ducts dilate in response to the tractive force of the collapsing alveoli that surround them. Eventually, you're left with a totally collapsed nubbin of a secondary lobule in which it's probably less than 5% of its original volume, and the original 1 millimeter central airway has now dilated to be nearly a centimeter. As this happens, you begin to distort the airways, and a flap or ball valve may be formed. If this happens, then you can get progressive enlargements beyond 1 centimeter for these honeycomb spaces. This is true honeycombing. And you'll notice that true honeycombing occurs in the mid and lower lung zones and is a strikingly peripheral abnormality. Take a look now and remember back to the appearance of the secondary lobule in the patient with diffuse pulmonary fibrosis. In diffuse pulmonary fibrosis related to cigarettes, directly related to cigarette smoke, we could see an entire secondary lobule. Here, there's 1, 2, 3, 4, 5, 6, 7 individual secondary lobules, and all that is left is now just a nubbin of the secondary lobule, and there's a dilated airway right in the center. This was once a complete secondary lobule. It's now almost completely collapsed in on itself. And these holes are what you and I see as holes in the periphery and lower lung zones, and this is true honeycombing. This is a true honeycombing cyst. So if we look at the difference between patients with diffuse pulmonary fibrosis directly related to cigarette smoke, so-called airspace enlargement with fibrosis, we see diffuse ground glass, but we see that the holes are more prominent in the upper lung zones. They are well circumscribed in places, and you could wonder, if you looked at these in isolation, could this be an area of honeycombing? It's very hard to separate by just looking at the hole itself. If we look at these holes and compare them to the holes of honeycombing in the patients with IPF, even though the pathophysiology is very different, they look very much the same. It is the location that helps us. And it's part of the reason why the diagnosis of honeycombing is so difficult and that there's so much disagreement. This was a study that was done looking at the inter-observer variability in the assessment of honeycombing, and you can see that the K values are quite poor even for expert radiologists. And the problem is exactly what we talked about before, which was that patients with emphysema and fibrosis can look very much like the patients who have IPF. The big difference really relates to where the holes are. So what I've tried to do for you is to show you the varying responses to cigarette smoke that occur within the lung. In fact, there are only 3 basic things that occur. You can either get inflammation, which is usually macrophages or some kind of dendritic cell. You can get emphysema, which is dilatation of the alveolar spaces and destruction of alveolar walls, or you get fibrosis. It turns out that most cases of open lung biopsies that I see in dyspneic smokers combine all 3 of these things. And as a consequence, I often, as a final diagnostic line, will call this smoking-related diffuse lung disease, and then describe the various findings, upper lobe, ground glass nodules that are probably respiratory bronchiolitis, more diffuse ground glass that could either be extension of those inflammatory cells or could well be fibrosis if I see areas of traction bronchiectasis. I look at holes in the upper lung zones and describe emphysema. It is not surprising that there's some degree of most of these changes in most biopsies in heavy smokers who come to open lung biopsy. Sometimes you can put them into an individual category of RB, desquamative interstitial pneumonia, pulmonary Langerhans cell histiocytosis, or diffuse fibrosis, or maybe even IPF. But I will tell you that most of the time it is some combination of these, and your ability to recognize the different findings and to place them under the category of smoking-related diffuse lung disease and explain which is the predominant feature will really be the most helpful as far as the clinicians and patient care. Thank you very much.